short of time a little. Nivian Madhyavanan, who is the chief instructor for this course, I call him the Virat Kohli of ophthalmology, and he is really fantastic both in anterior as well as posterior segment. He is really a very dynamic surgeon. Over to Nivian.
Thank you, sir. Respected teachers, senior ophthalmologists, my dear friends. So I'll be talking on phaco and colobomatous eyes. So I'm not going to go through the entire procedure as it's an instruction course. So I just want to highlight some of the key points and how we can make it easier, lesser complicated. So iris colobomas, we have a simple iris coloboma where there's only an iris defect or a coloboma along with a lens coloboma, but that's where the zonules are actually absent, not weak, and also the ones which have the retinochoroidal coloboma. And most of these eyes are actually smaller eyes, and usually you end up with harder cataracts. I think most of you must have experienced that. So we'll go by the first scenario, which is a very simple case. So it's a NS2 grade cataract with iris coloboma alone, and you can see the zonules that are missing here on retroillumination. So the first thing I would say is we usually plan for a phacoemulsification, and during the rhexis itself you can somehow assess and gauge about the strength of the zonules, because when you're not able to do the rhexis with your cystitome at that time, or when you're pulling it with your capsular rhexis forceps, you know those areas zonules are weak. So in this particular case, as you can see, there is no movement of the nucleus. So it did the rhexis. And as one of the senior doctors asked me the question, so initial for youngsters who are actually trying to start, you can actually make a limbal based incision. So this is not a purely clear corneal incision, because in case you land up with troubles, you can I prefer to actually extend a limbal incision than a clear corneal incision. So making a 3-planar incision here. These are just taking precautions because we have done these cases and we have experienced how it can go wrong. So these are just simple precautions we take to minimize the complications. Hydrodissection also, compared to other cases, you make it very slow. So you do a gentle hydrodissection and also a hydrodelineation. Because most of these cataracts, because of the deformity, they do not easily rotate. I think the previous speakers already admitted. So sometimes I avoid rotation in these cases, because even a mild rotation can actually break some of the zonules. And the choice of phaco, I think it is definitely surgeon oriented, because you saw the previous surgeons do all direct chops. So I see a lot of youngsters here. So you can do a stop and chop technique also. So it is basically whatever technique the surgeon is comfortable is what is the preferred choice of technique. There's no fast and set rule that this particular technique is better. This is the next point is, even in these cases, because there's a defect in the zonules, you always have this problem of the vitreous can come to the antechamber. So try to keep the antechamber always filled with viscoelastics. And the third thing is cortical, instead of aspiration, I call it the cortical stripping. So here what happens is you hold the edge of the cortical anterior fibers and literally strip it to the center before aspirating. Here I have not hit the foot, but you're not aspirating yet, because after doing all these phaco, you're suddenly thrilled and happy, and that is when you're trying to do a normal aspiration, you see the whole bag folding and come. So in that point you feel bad because you almost completed the cases. So this can actually also prevent that from happening. So once it comes to the center, then you aspirate. So you strip the cortex, bring it to the center, and then gently aspirate. CTR, yes, I prefer the option as most colobomatous cases, because there is a weak zonules. The size, yes, you can actually measure the corneal thing, and preferred size can be used 11, 13. So I just use the routine simple method of trying to make sure that one edge is under the bag, and then I use my Sinskey dialer to put the next edge. You can see there, the only thing you should make sure is you make sure when you see something, you make sure it goes into the bag, because once it goes into the sulcus, it is very, very difficult to find, and I think most times it sometimes becomes very difficult to retrieve these cases. So the choice of IOL, as long as there is no problem or there is no rupture, I think any of your IOLs can be suitable, and preferably in the bag IOL placement is the best. And one more thing, if you notice, you always like to prefer to keep the haptics wherever you find the maximum instability of the zonules is. So they also add some amount of stretch and keep the bag in stretched. This also helps you prevent post-operative phimosis, because most of the coloboma cases, when you make a smaller rhexis and you see post-operatively, there is more contraction of the anterior capsule. So this CTR and then putting the haptics on the side where you have the maximum defect can actually reduce those problems, what you see post-operatively on long-term follow-up. So the second scenario is when you have this lens coloboma also, you can see the flattening of the lens inferiorly, and also combined with a harder cataract. Yes, rhexis for any phaco, as you all agree here, is very, very key and important step. The only thing here is we should not get carried away by this defect, because when it comes to this area, we actually tend to make it larger, thinking that we are not in the center. So that one thing we should be careful, because once it goes little here, and we are almost closer to the zonule. So that is when the tendency of the capsule to run away is also more. So once you have a good rhexis, I think in this case we go on the clear corneal section. And phaco, as I said, again the choice is surgeon dependent. One more small thing I think they all overlook is like how your infusion is at right angle. So this, most of us in a hurry, we don't check because we have a huge list, because that flow of saline also is very, very important for your followability, and that also has a small impact on the outcomes of the surgery and not your surgery alone, because when you have saline flowing in different directions, it can actually not have a good followability. So make sure these small things are corrected before. And in this particular case also, we are doing a stop and chop technique here. So even though you use a little bit of more phaco energy than when you do a direct chop, the only point I like to emphasize is make sure there's no stress on the zonules. So you have to increase if you have to use more power, and always widen your trench for ones who are starting. The secret is when you have a 1.5 width trench, that is when you can see your phaco probe going smoothly and inside deeply. The other basics are the same till you get a nice good retro illumination. That's when you know how to stop. And in this case also, see, I'm not withdrawing the phaco probe, because once the antechamber collapses, that is when the vitreous actually from behind actually thrusts forward. So this is another technique that initial days, because you have a larger instrument, you can actually use a Sinskey and a dialer to actually break these harder cataracts and rotate it. And then break it into smaller figures. Make sure that you're not in a hurry. So you can see the capsular bag also. So I usually prefer to crack the nucleus and then bring it slightly into the center and into the pupillary plane, and particularly in these cases, because I don't want to catch the bag or have a rolled back in another way. So you can see everything is actually slowed down from your routine phaco. You take that extra few minutes that you would spend rather than a normal phacoemulsification, and then the rest of the things are the same that you could do in any other phaco. So this is another technique when you have these small fibrils remaining. Nowadays cataract surgery patients are more demanding, so you don't want to leave all these. So these sticky cortex that bother you, I call this we have this hydrojet. So you just put a saline cannula and you can actually wash away these frills that are stuck, because sometimes removing them with irrigation aspiration can be tough, and sometimes the capsule can also get caught. So I skipped the IOL part, but I think Ashwin has showed some beautiful videos of SFT. So after learning that technique, we have also employed it in certain cases. Initially, we were not doing it for colobomatous cases, and all of you here agree, they do complain of glare and sometimes of diplopia. So this is actually a beautiful and a very, very simple technique. So it's just a 90-10-0 Prolene suture that he takes. So just this is a mild counter traction that actually helps, because sometimes otherwise when you're pushing the needle, you can actually cause more damage to the roots of the iris, and that is the reason that causes building. So if you see, there's always a mild counter traction, and then you insert the 27 gauge needle. So this is what they call as the railroad technique, as you pass this needle inside and then bring it to the other side. So then he forms a loop. So I'm not going to go into detail. I think he's shown many videos, but in certain scenarios like the iris coloboma, it has been very useful. As you can see, you can also get nice round pupils, and the patient who's had these colobomas from young age is also symptomatically, and they have this new smile in the face when they see a symmetry between the two eyes. Trust me, it has happened. So this is a very simple and easy technique for these colobomatous cases. And then you can go ahead and do irrigation aspiration. So this was post-op 1 week. You can see some edema there because of the hard cataract, and this is at the end of 1 month. You can see a well-centered lens and a good anterior capsular rhexis coverage over the lens. So this is what actually prevents PCO, I firmly believe, than the type of lens you use. Have a good anterior capsular coverage over the IOL and have a nice rapage effect. The third scenario, I had to borrow this video from Ashwin because this is already an award-winning video, so I could not show you the whole video. So in certain cases where you have a large coloboma, they also published this in JCRS, vitrectomy-assisted phacoemulsification. So these are the cases that are prone for the vitreous to come forward, and also Summarize has already told you about these are small eyes, and that can cause the shallowing and of the anterior chamber. So this sometimes even when you're doing phaco, some amount of fluid goes, and that can also push the vitreous backwards. So what they have suggested is you actually make a 23 gauge trocar. I think anterior segment surgeons can also do it. It's very simple. And then debulk just some amount of the vitreous. So that itself causes deepening of the anterior chamber. And now this case starts behaving like any other case. So this is avoiding the area. Just do a mild vitrectomy. That is more than enough. And then you go ahead with your phacoemulsification. This has actually helped in many of these cases because when you have, even in nanophthalmic cases, we have done it in small eyes. It's actually a very, very useful technique actually. You will be surprised to see the amount of space you have in the anterior chamber. The other new thing that I described is also using the capsular hooks. So that also has some amount of stability. And I think iris hooks, Dr. Sujata Mohan has already explained in all our videos about the iris hooks. So thank you once again. So next we'll have the final speaker of the day, Dr. Mohan Rajan. And he'll be talking on the femto-assisted cataract surgeries. Thank you.
Thank you.